Dear viewers, welcome you all to our show OSA, that is the Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing masks and keeping distance with each other. Dear viewers, today our topic is a very challenging topic, that is Volkmann Ischemic Contracture. Is it very difficult to treat? We don't think so. As because of we have Ilizarov. So our topic is today the Volkmann Ischemic Contracture treated by Ilizarov. And the speaker is the one and only, the legendary Ilizarov surgeon of Bangladesh, Professor Mofakharul Bari, sir. I would like to request Professor Mofakharul Bari, sir, to join with us.
Thank you. Good afternoon, Tanvi. Thank you very much.
You're welcome, sir. Good afternoon. Dear viewers, we have two learned academic experts with us. One is Professor Novikov, sir, from Kurgan, Russia. He will join in the coming part of the program. And the another one is very enthusiastic, Dr. Samsar Huda, sir, from Patna, India. I would like to request Dr. Samsar Huda, sir, to join us. So welcome. Welcome to our show.
Thank you and very good afternoon to all, Dr. Dhun.
Thank you very much. Dear viewers, we all know that the Volkmann Ischemic Contracture is a very challenging thing for all orthopedic surgeons. Is it possible to treat it by Ilizarov? Yeah, definitely it is possible, and we can treat it successfully by Ilizarov. Now, I would like to request Professor Mofakharul Bari, sir, to share his screen with us, start his magnificent presentation regarding Volkmann Ischemic Contracture treated by Ilizarov. So please, would you please share your screen with us?
Okay. Thank you, Tanvir. And dear viewers, and today I would like to talk on a very important and very challenging topic for the orthopedic surgeon, that is Volkmann Ischemic Contracture, how we can treat by Ilizarov. So, you know, this gentleman from Germany, 17 August 1830, he was born and died in 1889, 28 November. And mentioned regarding this, his Volkmann's Ischemic Contracture in 1881. That is 59 years, you know. And this is what he stated, that paralytic contractures that develop within a few hours after injury are caused by arterial insufficiency or ischemia of muscles. So now, if you think about this volcanic ischemic contracture, a condition which is characterized by ischemic necrosis of the
Dear viewers, we're facing some sort of network problem. You all know that we're facing this problem every now and then. Hope Professor Mofakharul Bari will join us within a few seconds.
The most common etiological factors we can see here: neglected compartment syndrome, crash syndrome, and you can see here bleeding disorders, and as well as fractures associated with vascular injury. You can see here that I told you crash injury, prolonged external compression, internal bleeding, that is it can be in hemophilic patients, burns, snake bites, intravenous regional anesthesia. And you can see here, hemorrhage and edema may further compress the brachial artery and median nerve in this region. Supracondylar fractures, you can see in the right side of the humerus in children, is the most common precipitating injury. The branch of brachial artery may get impinged on the sharp proximal fragment against which it is held by lacerta fibrous. Now, neglected compartment syndrome, if you do the early diagnosis and fasciotomy, then we can avoid the development of the Volkmann's ischemic contracture. Regarding the treatment, it is very difficult for the orthopedic surgeons. And if you see here, the left side, compression of the brachial artery or impingement of median and ulnar nerves at the lower part of the elbow, of the arm or elbow, leading to contracture or necrosis of the flexor muscles of the forearm. You can see here the course of the ulnar nerve and the vessels. This is the ulnar nerve, this is the median nerve, and of course, this is the brachial artery in relation with the humerus and the radius. Now, look at the structure anatomical of the brachial artery. Brachialis muscle, ulnar nerve, or pronator teres muscle, and bicipital aponeurosis. And here the big muscles here, the brachioradialis muscles and the median nerve. So before going to do any kind of surgery, you should have to keep it in your mind regarding the all structures of the arm and forearm. Now, I told you the causes of this Volkmann Ischaemic Contracture: prolonged external pressure, that is tight dressing and cast, bleeding disorders, burns, and trauma resulting from any fracture in the elbow region or upper arm, especially supracondylar fracture of the humerus. You can see the distal above the epicondyle, and more common in children, fall on outer stressed hand. That's why we can explain in this way that distal fragment of the humerus moves upwards and backwards, proximal fragment sharp moves forwards and pushes median nerve and brachial artery, and hemorrhage and edema compresses brachial artery, and we can get the impingement of the median nerve. Here you can see very nicely, it is described here, the drawing you can see here, anterior displacement of the proximal fragment pushes the nerve and the artery. Here you can see here what we can see later on as complications of this type of fracture. Now you can see here A, B, C, and acute ischemia leading to necrosis, leading to contracture and necrosis of the flexor muscles of the forearm, especially flexor digitorum profundus and flexor pollicis longus. Severe cases, all flexors and all extensors are involved. Muscle tissue replaced by collagen that causes contracture. Nerve injury causes muscle dysfunction, sensory loss, and the ischemic pain. You can see here the most common forearm muscles have affected. If you look at the right side, here, FDS, flexor digitorum profundus. You can see a flexor pollicis longus, next most common one. And I told you that single most commonly affected this muscle, flexor digitorum profundus, flexor digitorum superficialis, and of course the pronator teres, pronator muscles. Now, by looking from the outside, severe pulse in the distribution of the median and ulnar nerve, you can see here in case of contracture, Volkmann, if you look at the elbow, it will be flexed, elbow flexion. Look at the forearm, it will be the pronation position. Whenever you see the wrist will be flexed. And if you look at the MP joint, will be extended, and thumb will be adducted, and interphalangeal joint will be flexed. So these are the common signs and symptoms that you can see in case of severe palsy, in case of Volkmann's ischemic contracture. Now, what are the symptoms? 5 P's: pallor, pulsishness of the skin, and pain, paresthesia, and paralysis of the flexors of the forearm muscles. Now, at the entrance to the flexor compartment of the forearm, Lesartas fibrosus fans medially from the biceps tendon. So this is very important. You can see here, this is from the biceps tendon, and beneath the Lesarta fibrosis, the brachial artery and the median nerve pass to enter the flexor compartment. How it goes, and then if you look at the anatomy, the median nerve accompanies the brachial artery beneath the Lesartas fibrosus and enters the substance of the pronator teres, passing in between its humeral and the ulnar head here. Humeral and the ulnar head. And then you can see the compartments of the forearm are superficial volar compartment, deep volar compartment, dorsal compartment, and mobile ward of the Henry. Now, tolerance of the tissue. This is very important. If you think about the muscles, functional impairment after 2 to 4 hours of ischemia, irreversible functional loss after 4 to 12 hours. And if you see the nerves, functional impairment after 30 minutes of ischemia and irreversible functional loss after 12 to 24 hours. So, the very important complications in the Volkmann's ischemic contracture are the deformities. Deformities is very dangerous in case of ischemic contracture. Mild type, deep flexors are partially involved that I told you, particularly flexor digitorum profundus, flexion contracture of one or more fingers which can be extended on hyperflexing the wrist, and resistant pronation contracture involving either the pronator teres or the pronator quadratus. Moderate type involves most of the flexor digitorum profundus, flexor pollicis longus, and part of flexor digitorum superficialis. Neurological deficit involving median nerve more than ulnar nerve is present. Deformity is intrinsic minus hand and diminished sensations in median and ulnar nerve zones. So, in case of severe types, all the flexor muscles are involved. Neurological deficit is very severe, joint contractions are very marked, and wasting of the forearm muscles. So now, what is it? Sequelae compartment syndrome results in claw-like deformity of the hand, ischemic contracture of the forearm muscles, and involvement of the nerves. You can see here, increased pressure compromises tissues. What are the tissues? Blood flow you can see, oxygenation, function loss, and nerves and muscles vitality. And if you see the perfusion pressure in a closed anatomic space, you can see here, and results in tissue and nerve damage. Now, incidence, 40% of the falling fractures of the shaft of the tibia, 18% are involving the forearm bones. Children with elbow and unstable radius fractures, Raymond et al. In JBJS, they have published a paper 2009, and you can see we can get the compartment syndrome in Shaska type 5 and 6. This is also very important for the orthopedic surgeons. Now, whenever you are facing with the Volkmann ischemic contractures, you must follow the protocol for management of this. If your skin condition is good, and if your skin condition is not good, what you can do here, you can go for neurolysis, you can do the excision of the fibrotic muscles, and good protective sensation you can get. What you'll get, you can see status of the extensor tendon. It is very good. You can go for tendon transfer. If not good, then FMFT for finger flexors. Extensor can be radialis longus to FDP, flexor digitorum profundus, or brachialis radius to FPL. And at the same time, you can do independent motor to APL. And if your skin condition is not good, then you should have to go for abdominal flap cover. So now I would like to very simple one MCQ. Fracture in children under 10 years of age. If question arises, you can see here tennis elbow, golfer's elbow, student's elbow, or supracondylar fracture of the humerus. Which was the most common? It's common is the D, that is supracondylar fracture of the humerus. Now, regarding the treatment, I'll go for the deformity, how to correct. Before going that, you should have to know the Ilizarov's law of tension and stress. Why I'm showing this? Because on the basis of Ilizarov philosophy and law, that is slow and steady traction on a living tissue creates a stress which is metabolically activated and which stimulates histoneogenesis, that is tissue genesis, myogenesis, neurogenesis, osteogenesis, and all kinds of genesis by Ilizarov tension stress law. Now you can see this is a case of VIC of right angle of foot with deformed toes. Can you tell me, dear friends, these are the cases how you can treat these kinds of deformities in case of VIC. Now, if you have Ilizarov in your hand, you can at least do something. Without the Ilizarov, you cannot correct these kind of deformities. See, look at this gradual destruction, and you just see the sole of the foot. Your foot is almost corrected from the valgus to varus. Now, exit is almost, gradual sequentially. You can see this is during treatment. Patient is going to remove his apparatus within a short time. Now, here you can see 7 years old boy after Volkmann's ischemic contracture of the right forearm and the hand. Look at this here. The four cases symptoms I showed you: wrist pronation, thumb adduction, and flexion of the RP joint, extension of the MP joint. Now, here you see the pronation, see the almost 90-degree. This is radiograph of the left forearm. The patient come at place. You can see here the skin condition, contracture, and then I put the Ilizarov, one ring here. See, look at this, another ring here. Put in the hand, and this is, if you look at this, with hinges, and gradual destruction was applied to correct the deformities. And radiograph of the left forearm after 4 months follow-up, you can see with hinges. This is almost, when you are given destruction, your skin and muscles, nerves, and vessels all are getting stretched, and as a result, you are getting a supple hand. And look at this, after 5 months follow-up, this is before, this is final appearance of the patient. Look at the wrist, and the look at the hand, and this is after 5 months follow-up. Look at this 12 years old girl. Again, Volkmann's ischemic contracture of the wrist and the hand that I'm showing you. Wrist pronation. This is pronation of the forearm, thumb adduction. Now, look at this interphalangeal joint flexion, and look at the X-ray of the right side. And then what we have done, again, close-up view of the mini fixator in the left forearm. And finally, we got the clinical occurrence of the patient after 4 months of follow-up. And this is IP joint, interphalangeal joints almost straight. And look at this 6 years old girl, again, VIC of the left, you see forearm, muscle wasted. This is wrist pronation, and flexion of the wrist, pronation of the forearm, and thumb adduction. Look at this here. This is the X-ray of the hand before surgery. Then you put the Ilizarov in the hand, and gradual destruction. 2 ring constructs in the forearm. Here is one with hinges. This is the radiographic view. This is the clinical appearance. Patient with Ilizarov fixator. Gradual destruction. Follow-up after 7 months. So, this is, you can see the IP joint and the metacarpal joints and clinical appearance of the patient after 11 months follow-up. This is the right hand, this is the left hand. Just to compare this one with the this one. This is before radiographical result of the hand. You can see patient is happy, and she can do his any kind of activities with the left hand. So, dear friends, what I've shown you, the difficult cases, that is on the basis of evidence that I've showed you. the science and surgical skill of the surgeon. And of course, this is the combination of the biology and at the same time the mechanical stability of the apparatus. And by Ilizarov technique, at least you can do this kind of deformities of the Volkmann ischemic contracture. These are the books 92 and 93, my publications. Thank you so much. I want to convey my gratitude to this great scientist, Gabriel Abramovich Ilizarov, for giving us a new laws by which we can do lots of deformities and we can correct, we can help the people. Thank you so much for your kind attention.
Thank you very much, sir, for your great presentation. And I think many orthopedicians will learn these things and overcome the Volkmann systemic contracture by using the Ilizarov. Now, I would like to request Dr. Shamsul Huda, sir, to say something regarding the presentation, and if you have any questions to Professor Mufakrul Bari, sir. Dr. Shamsul Huda, sir, please.
Thank you, Dr. Tanvir. It was such a wonderful learning, sir, because in our state, most of the cases of VIC has been being treated by plastic surgeons only. We don't usually apply Ilizarov on it, giving extensive skin incisions and large procedures are being done in small kids. So seeing this, we can do most of the cases of deformity of VIC with Ilizarov, sir. My question to you, sir, that in your experience, if you are correcting with Ilizarov, my first question is, sir, do you do it completely with Ilizarov, or you do also get support of plastic also, sir? So you are doing with complete Ilizarov, or you are using plastics also?
You are completed or need any help of plastic surgeon?
That I showed you. These are all difficult cases, late cases. These are the when your muscles and all joints are contracted. I can go for Ilizarov, and at the same time, I go for the support with the help of the physiotherapist. You know, see, this is the sometimes I take the help from the plastic surgeon also. Okay.
My second question: if you are having deformity of elbow, wrist, and hand joints, do you do it in a staged way or simultaneously, sir?
It depends on cases. You can do simultaneously in the forearm, in the wrist, and in the IP joint and MP joint. Gradually, you can go for by Ilizarov. And in these type of cases, I do only the stage wise gradually by elbow, by doing the forearm, wrist, and MP and IP joints. Simultaneously, I go for correction of the deformities in all levels and with wires.
Right, sir. One more question, sir. In your experience, sir, post correction, have you faced any cases of subluxation of joints anywhere? Subluxation, sir.
So yes, it happens whenever you don't put your hinges in the wrong position. If you put your hinges, then you can get subluxation. The beauty of Ilizarov is that when you are getting subluxation or you see with the X-ray, you can correct it easily. That is the gradually you can do that. And so placement of the hinges, if you mismatch the hinge, then you can get it. And at the same time, you can correct it also.
Right. So my last question, sir, what is the rate of recurrence post correction, sir? Rate of recurrence.
Yes. Overcorrection is always advisable in case of here. If you don't do overcorrection a little bit, 30 to 40, 45 degree, then you can get recurrence again. Okay. So after removing or dismounting the Ilizarov apparatus, it is advisable to go for vigorous physiotherapy and use of sprintage. Okay. And as a result, you can get a very good functional activities of the hand. Okay. Leg also.
Thank you, sir.
Thank you very much for wonderful questions. Already we have learned many things from this type of questions. Sir, I have one question to you, sir. As you are doing it gradually, then what is the process of this gradual destruction? Is there any law of gradual destruction like the osteotomy in case of Volkmann ischemic contraction?
You can see whenever you have applied the Ilizarov in the forearm and the wrist and the MP joint and the IP joint, you can go distraction gradually by 2 times or 3 times a day. 2 times, 3 times a day. Sometimes not in everywhere. It depends your case. If you see the patient is complaining pain, then you can go for 2 times a day or 3 times a day. Sometimes, depending on the big gap, that is big contracture, you can go for 4 times a day. Whenever here you are not doing any kind of distraction in the bones, you are doing contraction correction by applying the apparatus in the soft tissues. That's why it depends on your case, and you can go for 2 times, 3 times, or 4 times. Even then, patient complains pain, you can stop for 1 or 2 days. Then you can start again.
Okay, sir. Do you do any
Another thing I would like to tell you, when your hands are like this, contracted, you go for distraction for 5 or 7 days, and then you release your hinge, allow the patient to go for physiotherapy. Again, you apply the hinge. Again, you go for 5 or 6 days, 7 days for distraction. Again, you stop, then exercises. Okay. These are the theories. These are the basic principles for correcting the contracture in case of raised elbows and IP joint and MP joints.
Thank you very much, sir. Do you do any type of Z plus T with gradual retraction? And in
Yes,
combination
that
with
depends also. That depends. Sometimes it is needed. You can go for jet plasty. If you need, if your skin is very bad, sometimes you get psychiatrics. That is, skin is very bad. Sometimes it is very difficult go for correction of the jet plasty. Then gradual distraction by Ilizarov, law of tension and stress. It gives so smooth, scar tissues become supple and softened by applying this Ilizarov principle.
so if we do Z plus T along with distraction, then what will be the distraction rate? Is it the same or we will close
Depends on your. I got your question. When you have done the jet plasty, and for example, when you are doing sometimes tenotomy, tenotomy for the ankle, then you have done tenotomy. After 2 or 3 or 4 days, you could go for distraction. In jet plasty also same.
Sir, do you use any small hinges in the finger joint, sir? Because normal hinges won't adjust here. Do you use mini hinges or small hinges joints?
A small hinges, mini hinges you have for the fingers. Big hinges you cannot put here. Okay. And the wrist you can put the big hinges. Here small hinges you have. Very little hinges, mini Ilizarov hinges. Size is very small. So these are the very difficult cases. And I tell you really, you can help with the Ilizarov. The Ilizarov principles.
Right.
That is law of tension and stress. This is very important. This is the basic thing. Most of the orthopedic surgeons, they don't know the law of tension and stress.
Exactly, sir.
Most of the orthopedic surgeons, they know only the Ilizarov putting words, nothing. No. Slow and steady traction on a living tissue. Before Ilizarov, lot of external fixator was discovered by the lot of orthopedic surgeons. Yeah. But they have not given the principle, biological parameters. The principles law was given by the Professor Ilizarov. That's why his theories and everything is still accepted all over the world by using the other external fixator also. Everybody is following the principles of Ilizarov. Okay.
Sir, one last question, though it is not directly related with this topic, but somehow it is related, as because of we came to know that you are using Ilizarov in case of peripheral vascular disease, and you can increase the blood circulation by Ilizarov. We saw that in your earlier presentation. Is it possible to apply Ilizarov before Volkmann's ischemic contracture? And can we prevent this type of Volkmann's ischemic contracture by applying Ilizarov in the early stage of the trauma?
Early age trauma, I don't have idea. Early age trauma, that means when you are getting compartment syndrome with necrosis. These are
Yes,
all
sir.
late cases I've shown you. With necrosis, in that case, you don't need to go for, osteotomy here. Induced angiogenesis, to get the induced osteogenesis, you have to go for osteotomy and osteotomy in the bone, and then you go for distraction. As a result, you get a arterioles, venules, and capillaries, new formation of this, and that will help in case of the late cases. In peripheral vascular disease, I am doing every week 2 or 3 cases PVD, in PVD and diabetic patient in diabetic hospital. Every week, 2 or 3 cases I am doing. I tell you, this is TTT. I told you, tibial transverse technique. That is in diabetic foot, I told you, already published in American journals. That's TTT I am applied in PVD, peripheral vascular disease, in atherosclerosis. I'm telling you, this is a new thing for all diabetic patients. Most of the patients, they are suffering with atherosclerosis. Blood flow in the four regions: popliteal artery, arteria dorsalis pedis, anterior tibial artery, and posterior tibial artery. Four arteries are always involved 70%, 80%. If you do the TTT, or even then don't TTT, you do a segmental osteotomy and just you increase the vascularity, just distraction, you'll get a fantastic result. Before surgery, I do the duplex, color duplex. And after surgery, 2 or 3 months, I do the again color duplex. There are a lot of changes because you have the documentation. Before surgery, you do the color duplex. You can get the how blood flow of these four vessels before it was and after doing the Ilizarov surgery. That is called induced angiogenesis. And that is the beauty of Ilizarov. No other, vascular surgeons, they cannot even but doing angiogenesis, distraction angiogenesis, you are getting arterioles. This is authentic. Professor Shipsov, I have seen he has done 480 cases of atherosclerosis. Now I'm totally convinced, and I'm doing this surgery in diabetic hospital in Bangladesh Institute of Health Science, and they are getting very good results. So this is the new thing. And
Thank you very
one
much.
message, Shamsuluda, Satish Nasari, 1 month back, Satish Nasari from
Yes, sir.
Bengal
Welcome, sir. Yeah.
in India.
Sir, we are facing network problems, sir. We cannot hear you properly, sir.
Yes, sir. We cannot hear you properly, sir.
Dear viewers, hope we can hear our professor in a few minutes. So, we cannot hear you, sir, properly. There is uh, I think, network jamming there.
So in the next session, can we request sir to show a demo frame for VIC small hinges? Because
Yeah,
small hinges are
definitely.
easily available here. Yeah.
It will be very helpful for
Complex frame.
all of us.
Yeah, this is a
Yeah.
very complex frame. If sir can show one demo of small hinges deformity, multiple joint deformity correction like this, it will be really helpful for us. Yeah. And doing a semester.
Yeah.
Yeah.
This is a very complicated and
Yeah,
But we
exactly.
should all learn how we can
Yeah,
apply the hinge and why we can apply the
yes.
hinge. And
Yeah,
what about the small
that is
hinge
a very important stepwise
balances?
application. Yeah, that is very important.
Yeah, that's very important. Yeah, definitely. Dear viewers, we all came to know that we can apply Ilizarov in case of Volkmann Ischaemic Contracture, as well as we can apply it in case of peripheral vascular disease and as well as in diabetic foot also. And yeah, it has been already proved that in case of diabetic foot and peripheral vascular disease, we can apply Ilizarov and we can get magnificent results. As well as in Volkmann Ischaemic Contracture, we have already shown it in our presentation by Professor Mofakarul Bari. Hope all the Ilizarov surgeon will love these things, as well as a new surgeon will be encouraged to treat Volkmann Ischaemic Contracture, a very challenging thing by the Ilizarov. I would like to thank our honorable speaker, Professor Mofakarul Bari, for his magnificent presentation, as well as our honorable academic expert, Dr. Shamsudda sir, for being with us. And I'd like to thank Raj TV for helping us, as because of without Raj TV, we cannot arrange this type of academic program, and definitely the Pharmaceuticals Limited Bangladesh for sponsoring our program. I'm Dr. Mohantanvir sir saying bye-bye to all of you, and hope we will connect in the next Friday with another magnificent topic of magical Elizabeth. Till then, bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.